So happy to be at EHA, and I'm presenting some exciting data looking at a agent called HU5F9, both alone and in combination with azacitidine in patients that have high-risk myelodysplastic syndrome and acute myeloid leukemia. So just briefly on the background, macrophages are known to be key effectors of the innate immune system and basically can recognize what we call eat me signals to then induce phagocytosis and kill cancer cells. And importantly, CD47 is the most important negative immune checkpoint to basically block what macrophages can do against the tumor cells. And at least on AML, high CD47 levels have been associated with inferior overall survival. And so 5F9 is a first-in-class IgG4 antibody that can inhibit the interaction of CD47 with SIRP-alpha on macrophages. The importance is that the eat me signals are really largely only expressed on cancer cells, with one notable exception being old red blood cells, which I can comment on a lot. But this leads to potential selective elimination of cancer cells and really unique cytotoxicity from this. And preclinical models do support the combination with azacitidine. And so we ran, in the data that we're presenting at EHA, is both alone as well as combination with azacitidine, again in high-risk MDS AML. These are older patients, so the median age was over 70 years of age, with the vast majority having high-risk and poor-risk features such as adverse cytogenetics or therapy-related disease. The way that the dosing is given is the 5F9 is given a priming dose, and then over 2 weeks is worked up to a full dose, and it's given weekly at that point, along with the standard azacitidine schedule. As far as safety, the drug's been very well tolerated, really without any exacerbation of known azacitidine side effects. It does cause anemia from clearance of old red blood cells, so that's the one cell that can express these eat me signals. But after the first month, typically hemoglobin gets back to baseline and it improves over time. And importantly, out of all patients treated to date, only one has been discontinued from an adverse event, and that was related to a severe infusion reaction. So when we look at response evaluable patients, we did have 1 out of 10 patients respond in the single agent cohort. But I think excitingly, when we look at combination, over 60% of AML patients responded and 100% of MDS patients responded, with a complete remission rate of over 50%. Additionally, the median time to response is quicker than what we would expect at 1.9 months. That's significantly quicker than azacitidine alone. And I think we see the vast majority of patients also having transfusion independence, hematologic improvement, and we see nice deep level of remissions with clearance of cytogenetics and MRD negativity. So I think in conclusion, our early data really show quite high combination results with significant efficacy both in high-risk MDS and AML, and the future direction is expanding both of these cohorts.